Hi, Philip.
Hey.
The waiting room is cleared as of now.
Okay, I've got 12:01 my time, but 1:01 Eastern time, official time. My name is Ron Poole, the Pharmacy Technical Advisory Committee Chair to Medicaid. We, as far as I can count, we have 5 out of our 7 members on here, and the other 2, Matt had somebody get sick and had to fill in, and Jill, I believe, is traveling with her job. So I think everybody else is on here. Philip, Rosemary, Paula, Ron, and Meredith. So welcome, everybody. Hopefully you all got my copy of the minutes that Aaron had sent me, the corrected minutes. So if you've had a chance to review them, do we have any changes? If not, do we have a motion to approve?
I give a motion to approve.
Second.
All right. Motion by Paula, second by Philip. Any discussion? All those in favor say aye.
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 And any opposed? Okay. Let's, next on the agenda is old business. I just wanted to bring it to everybody's attention that Department of Medicaid Services, Commissioner Lee sent us out a notice on July the 11th that when we were talking about, we made our motion to pass and report to the MAC for the P&T committee to review the OTC list skin protecting category. DMS's response is that they are, the Medic Impact published list will be revised to reflect more detailed description of covered products. So they've addressed that one. We had a motion passed for DMS and Med Impact and the P&T committee to add additional OTC products. And we had a pretty detailed list, thanks to Paula, and had a few other entries from other people. And then DMS again is currently in the process of completing a full review of current OTC list. DMS will consider the above recommendations pursuant to federal regulations. So they are acting on behalf, trying to really come up with a detailed list that hopefully can accommodate more therapies, in my opinion, for our Medicaid population. And then we had a recommendation, and this is all from the May 26th meeting. But as previously noted, DMS is currently, motion passed for DMS, Med Impact, and P&T committee for the eczema class be reviewed for additional product considerations. Their response was prescription immunomodulators for atopic dermatitis will be reviewed during the November 22 P&T, which I'm assuming is the very next scheduled one. OTC products are not reviewed by the P&T committee. DMS has confirmed the NDCs listed above, and that's basically all the CERAVE products, CERAVE, if I'm probably butchering the pronunciation. But there's a lot more products that should be out there, or it may have just been defined better of the different options that we have there. They are currently covered by Med Impact, all of these Sarabi or Saray products. DMS will further evaluate other topical OTC skin protectants with the current OTC review. So they are really doing that review. I'm assuming probably as we speak. I'm sure it's going to take several meetings to go over that, but I was, very appreciative of the response. And if anybody has any comments on that or anything we need to contribute to that committee that's reviewing that, just let me know and I can, pass on the comments to them. And this is technically a specially called meeting, so everything on our list has to be, the only thing we can discuss is on here, but I do want to let people know that when we have our regularly scheduled meetings, we have a little bit more, leeway to discuss like things. And I thought that was the case, but, several times we would try to discuss things and we would get shut down on that. But on a specially called meeting, same thing with the Board of Pharmacy when we had specially called meetings. It is, what's on the agenda. So when we get to our next meeting, which we did have a change in that, is it'll be August 17th. Because of the specially called meeting, we wanted to put some time in between there instead of August the 10th. But Aaron's working on that to get everything worked out and send it out to people. On new business, I've got a person who's going to speak to this on here with us, but I'll set up the situation. First of all, on pharmacist provider status, the vaccination consultation. This is pretty lengthy. This was an 11-page document, so I've got it down to a page and a half, and that includes a few questions at the end. So I'm going to get through this. But in a memo that CMS put out dated 5/12/22, CMS interprets the medical early and periodic screening diagnostic treatment, that's EPSD, benefit to require states to provide coverage for standalone vaccine counseling to Medicaid beneficiaries under the age of 21. This interpretation applies to standalone vaccine counseling related to all vaccines covered for beneficiaries eligible for EPSD. State expenditures on standalone COVID-19 vaccine counseling for beneficiaries are not eligible for EPSD, and state expenditures on standalone vaccine counseling related to vaccines other than COVID-19 vaccines are federally matched at the otherwise applicable federal medical assistance percentage, or FMAP. Standalone vaccine counseling has been shown to help address vaccine hesitancy by helping beneficiaries and their families learn about vaccines from trusted healthcare providers. Coverage of standalone vaccine counseling could help states increase COVID-19 and other vaccination rates for Medicaid and CHIP beneficiaries, especially among children. During the COVID-19 public health emergency, there's been a decline in the number of childhood vaccines provided to Medicaid and CHIP populations, except for influenza. Vaccine counseling is an important tool available for all vaccinations, but is particularly important during COVID-19 public health emergency as families seek to have their children receive routine vaccinations and well child visits. As of December 2nd, 2021, CMS interprets the Medicaid EPSD benefit to require states to provide coverage of standalone vaccine counseling to Medicaid beneficiaries who are eligible. Talks about the interpretation is based on a subsection of their rules in their act, under which states are required to cover health education as part of the EPSD benefit. Under the updated interpretation of EPSDT benefits, states must cover standalone vaccine counseling for all vaccines covered under EPSD, included both COVID-19 and non-COVID-19 vaccines, regardless of the federal matching percentage for their expenditures on the standalone vaccine counseling. State Medicaid programs are expected to give all provider types authorized to administer COVID-19 and childhood vaccines under the HHS COVID-19 PrEP Act declaration an opportunity to enroll as Medicaid providers and receive Medicaid payment, not only for actual delivering of injecting the vaccines, but also for standalone vaccine counseling about these types of vaccines provided to beneficiaries eligible for EPSD. States may establish separate payment rates for standalone vaccine counseling or explore other payment methodologies to recognize additional costs associated with vaccine counseling that are not otherwise paid as part of the state's usual payment rate for vaccine administration or for comprehensive office visit. States that choose not to establish separate payment rates, associated billing codes for standalone COVID-19 vaccine counseling provided to beneficiaries who are eligible both for EPSD and the ARP COVID-19 vaccination coverage could reimburse for this mandatory coverage through existing payment methods, such as the payment for comprehensive office visit or the payment rate that state has already established for vaccine administration. States that do not currently cover and reimburse the standalone vaccine counseling for all other pediatric vaccines covered under EPSD for persons eligible for EPSD benefit will need to submit a reimbursement state plan amendment. A comprehensive descriptive payment method for standalone vaccine counseling must be included in the reimbursement section of the Medicaid state plan. So basically, a provider should be, pharmacists should be able to enroll as a provider under Medicaid and should be able to bill and be paid for these counseling vaccination services. I didn't see Fatima on here. Aaron, can you look to see if she is?
Hey, Ron, I'm here. Can you hear me?
Okay, I'm sorry. Now you popped up. So we'd like to, if you need to get back with us on these questions, but what we'd really like is to get some feedback from you, certainly, and Commissioner Lee. So in light of this CMS requirement, can the Kentucky Department of Medicaid Services provide guidance on how the department is planning to satisfy this requirement?
Sure, I can provide an update here. The way it'll work is, we'll open up the vaccine counseling HCPCS code to go through on a CMS 1500, and we'll open it up for pharmacists to directly bill on the CMS 1500 for that HCPCS code. So that's how we'll address the vaccine counseling piece.
Okay, and that's going to be billed obviously on the medical side, correct?
Can you repeat that?
That's going to be billed on the medical side?
Yes, that's correct.
Okay. And it's my understanding that due to the implementation of Senate Bill 5, the Department of Medicaid Services recognized significant savings. So, could some of these resources be allocated to allow Medicaid to add pharmacists as provider to satisfy this requirement of CMS? And I think you've already said that you're going to, the biggest thing that, as you know, Fatima, being a pharmacist, it's embarrassing today that we still have on the federal level Medicare not recognizing us, which we've been working on that for a very long time. So the main thing is we want to be able to bill as pharmacists, not have to do incident to billing for this type of service. So I guess to add to that, to this discussion, do you have any explanation or details yet on any issues of adding the taxonomy codes? Other practitioners have been added as providers. Will pharmacists have their own taxonomy codes and be able to bill direct on the medical side without any issues?
At this time, it'll just be opened up for that one HCPCS code via the CMS 1500 in order to meet this requirement. Anything further than that will not be allowed for pharmacists at this time. But this has been an ongoing conversation that DPS has had with groups like these with regards to full-blown provider status. So we're well aware of the concern that you all have, but for now it's meeting CMS's guidance and with regards to vaccine counseling.
Okay. Kathy, Hannah is on here with us. Did you care to make a comment on that?
Yeah, Kathy Hanna, and I am the MAC representative for on the MAC, the pharmacist representative on MAC, just full disclosure, and work at American Pharmacy Services Corporation. So I just want to give you all my background a little bit. So Fatima, is that from what I'm hearing from you, then we will not be, am I understanding correctly that we won't be able to enroll as a provider under Medicaid? Is that what I'm hearing?
At this time, that's not being allowed here, just because of the system edits and provisions that would have to take place. But we are, opening it up with regards to what CMS is asking in terms of the vaccine counseling.
Well, I guess I just want to get clarification, because when I'm reading this, it actually says that they will be, to enroll as a Medicaid provider. So it sounds like you're allowing to bill, but you're not allowing to become a provider in that process. Is that correct?
That's correct. The vaccine counseling piece is being met, and that's our interpretation, is that, as long as the vaccine counseling piece is being met, we're meeting the requirements of CMS. And we've had meetings with CMS where other states don't recognize pharmacists as providers as well, but the vaccine counseling piece is allowed to go through.
I guess, yeah.
I know we have language in Kentucky that recognizes us as pharmacists as providers, healthcare providers, because that's been a bone of contention. We got that accomplished several years back. So I guess I know Kathy's been working on this on the professional development side for some time. If you don't care, Kathy, go ahead and comment on how this relates to House Bill 48. And
Yeah, just point of reference, Ron wanted me to, talk to you about this. Of course, House Bill 48 did not affect Medicaid. That was not written into law, but basically, in a nutshell, it says that a pharmacist must be paid for by an insurer or or someone who's contracted with the insurer for any service within their scope of practice at a rate similar, the same rate that you would pay any other healthcare provider, such as an advanced practical nurse or a PA or a physician. So that's kind of in a nutshell for any services which are in their scope of practice. And so it just, this kind of plays into this a little bit, that we really need to be listed as a provider for these services as well. And, I kind of feel like, our Medicaid population could really benefit from some of these, like smoking cessation and other services that we can provide, flu and strep testing and that type of thing, which were within our scope of practice. So, as well as collaborative care agreements. So it just appears that we need to move in that direction. And I guess I'm just trying to figure out, I'd love for somebody to sit down and tell me where the issues are, because we can add other providers to the Medicaid rolls using their taxonomy code as that individual. So I guess, when I look at this, I see the CMS thing and I understand how you all are interpreting, but it basically says enroll as Medicaid providers. And so I guess I'd love for somebody to sit down and tell us how can we, where we've had this discussion many, many times, and it's not just in this arena, but what are the barriers? Fatima, can you tell me that, because I want to understand, really.
And just to add, Fatima, is that, I know I've talked to enough legislators that was in the room with Medicaid when House Bill 48 was discussed. Medicaid asked for this to be excluded from this particular law because you were going to work on this on the backside, that you were going to come up with your own way to involve pharmacists as providers, and whether we're getting paid for it in other states or not. I mean, you got, point of care testing for acute uncomplicated UTIs, group A strep, flu prophylaxis and antiviral therapy, colorectal cancer screening, TB testing, pharmacogenetic testing, anticoagulation monitoring. You got your education and potential prescribing protocols that are already approved by the Board of Pharmacy of tobacco cessation, alcohol use disorders, travel health, allergic rhinitis evaluation therapies, emergency contraception, anaphylactic treatment, opioid overdose with naloxone protocols, expanded immunization protocols that's been in place probably the longest. And then they're currently working on oral contraceptive evaluation and prescribing. And just to add to that, I mean, there's been a new drug application put in by a company just last week to have over-the-counter oral contraceptives. And then you got just your education monitoring and administering programs of opioid use disorders, long-acting injectable for antipsychotics education and administration, your adherence education and packaging, and then just plain education and recommendation programs of self-care conditions for dietary supplements, self-care diabetic testing, OTC probiotics interviews and recommendations, transitions of care from hospital or rehab unit to home, chronic care management, working with patients with 3 or more chronic disease states to manage their conditions and drug therapy, and then remote patient monitoring of real-time blood glucose monitoring, real-time peak flow meter monitoring, real-time blood pressure monitoring, and real-time weight management monitoring. So there's a lot of programs that are going on here that can save the state a lot of money and put our Medicaid population into a better quality of life. So it would be nice if we, being this was put out there that to leave, Medicaid wanted to leave themselves out of the bill itself, to know that somebody's actually working on this to develop pharmacist clinical services that they can be paid for. So I just want to know your comments on that, because if you all truly want to shut this down and make sure nothing happens, then we got to go back to the legislation and do something. But just wanted your comments on this.
Sure. So, a lot of the services that you've mentioned, are services that are provided by mid-level practitioners, primary care providers, and et cetera. And with that being said, we would have to look at the real fiscal impact that these services take if we shift those patients into the pharmacy space, what rate we would pay them at and what that would look like from a budget perspective. So, a lot of these things are and some of the budgetary impact analyses may have preceded my time, but we can certainly look into what it would cost and report back to this committee.
Okay. So at this particular time, there's been no work in this direction.
Not during my time here. No.
Okay.
I just want to add to Ron's thing. I mean, I understand, some of these are being met by other providers, but the patient access from the pharmacy standpoint, I mean, we are the most accessible healthcare provider out there. We're there and we're in the communities as well. So, I just want to make sure to put that little, note in there as well, because I know that in the pharmacy that I trained my students in, when we started doing flu and strep, we met that need when the doctor's offices were closed, when no one was around, and those patients got care. But unfortunately, our Medicaid population was not able to access that care. And that's where I'm speaking from. I think that pharmacists can provide these services And that we, it's a shame that our Medicaid population does not have the same access that other individuals might have. That's all.
Can I ask a question, Ron?
Yes, sir.
So my question is, who is the decider at the state? I guess this is for Fatima, if you could help us understand who is the decider on adding that pharmacist as a provider?
So it's a collective decision. It boils down to the pharmacy department as well as DMS leadership, so the commissioner's office and that level of leadership. And then, we also not only have to look at the financial piece of it, but we also have to look at the system changes, that a lift like this would require. And system changes also boil down to monetary impacts. So, we'd have to take all of that into consideration before making such policy decisions.
Yeah, I will say, I think I'm just going to echo what Ron and Kathy said. A great example of how accessible pharmacists are. We started a collaborative care agreement protocol with one of our physicians to do UTI testing. And so we now have people come in at least once or twice a week saying, can I just, they pee in a cup, we do the ELISA test and we prescribe therapy through the protocol. And they're more likely to seek care because they don't have to make an appointment. They can just come to the pharmacy and be seen. I think this is just like that. It's another example. So I support, evaluating that. And I don't know what meeting that decision's made in, but I support everything Kathy and Ron have said here.
And just to point out, Fatima, you may think that some mid-level practitioners already do these things, but I can assure you, as being on a hospital board, that the need for transitions of care is not being met. Chronic care management is not being met. They're looking for practitioners that can take this. So we're doing incident to billing through physicians' offices doing these programs already. So it looks like the physician's doing it, but it's actually a pharmacist doing it. Remote patient monitoring is a fairly new CMS program for actually improving medical condition monitoring and also just their overall quality of life. But when you have real-time feedback, you can make adjustments very quickly. And it's the pharmacists that are stepping up to the plate and getting that done. But again, we're having to do it through incident to billing. But there's a lot of these programs that I mentioned, certainly pharmacogenetic testing, other things like that we actually had KMA reach out to us on the colorectal cancer screening because they need to improve their numbers of people getting screened. So they reached out to us to get it done. Like I said before on just the rollout of COVID vaccines, pharmacists gave 70% of the vaccination. So I know we're doing the job. I think it's, here in the 21st century, it's embarrassing that we're still having this conversation. And I would feel that you being a pharmacist would be an advocate for us developing these programs and being able to get people treated a lot more efficiently and quickly, and certainly more convenient for the patient also.
Ron, I just had a clarifying question. You mentioned that in many instances, it looks like a physician is providing the services, but it's actually a pharmacist. Can you just expand on that, please?
Well, and whether it's transitions of care or chronic care management or remote patient monitoring, the effective programs are utilizing pharmacists to be able to come in and help manage the medical condition with someone with at least 3 or more chronic disease states. So they're the ones making the drug recommendations back to the prescriber on what to do there. Certainly in transitions of care programs, you have pharmacists giving feedback to the hospital because they're trying to reduce readmission rates. So the best programs have that connection with a pharmacist or a pharmacist network out there to give feedback to hopefully prevent somebody from having to go back to the hospital. And certainly remote patient monitoring, physician groups, and they don't want to mess with the monitoring. The monitoring comes back to us in real time, and we're able to see trends and be able to report back again to those physicians to change of therapy if we need to, or alert them to problems that the patients are having, whether it's tolerance or whatever. And certainly on transitions of care, a lot of it's about formulary issues. So it's working with the physicians and giving them feedback and giving them recommendations on drug therapy management. But it certainly could be autonomous still, us to be able to bill for those things directly instead of having to go through a physician practice and having to work out arrangements with them to, for us or them to do the billing, and having monies for different things coming in and having to separate those.
I can echo that, Ron. We have one of our pharmacists, Amy Adams, works in the internal medicine group clinic at UK, and they do chronic care management, but none of that works unless Amy's there. These physicians are not going to sit down and peel apart the onion of 10 plus medications on hand and make sense of it. They don't have the time or the energy. And that whole program, the medication piece, doesn't work unless the pharmacist is there. But I don't think you see that, as you said, at the billing level. Her name's not on there. It'll be the attending who's seeing that patient in clinic.
Thanks, Phil. Okay, I guess the only thing that I would ask at this time is for at least to be able to make a motion and report to the MAC on next week, July 28th, about our recommendation to support the movement for pharmacists being recognized as full providers, and working on different payment models and taxonomy codes and billing codes for pharmacist clinical services.
Ron, I'm not sure I can repeat everything you just said, but I would make that motion.
Okay. All right, motion by Meredith,
Second.
second by Philip. Any further discussion? All those in favor say aye.
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 Any opposed? Okay, motion passes. And Aaron, I'll get you the language on that
Thank you, sir.
when we're done. Okay, on the NADAC pricing, gotta get off full view here so I can bring that up. Getting a lot of reports from pharmacists that are able to look up pricing issues. One particular pharmacist gave me some exact updates, like Eliquis 5 milligram has had 2 updates since the first of the year, yet we're still being reimbursed off of NADAC as of 1/1/22. On Myrbetriq ER 25 milligram, the NADAC age on that is 1/12 of 22. And I know of one price increase after that date. But basically I've been inundated with like Janumet 50/1000, again, 1/6 of 22, and that's a drug that's gone up twice since then. So Fatima, I guess we should have said, when we were trying to speak with, you and Commissioner Lee, when we were trying to get the language down on what we recommended to the MAC and CMS on recommendations for the lesser of payments, is leaving out the word, current NADAC. Because if they're going to let the NADAC, if they're not going to update the NADAC to the current price, then I don't see how that is ethical, first of all. And I certainly would hope that there would be an update and a rebill and a reimbursement back to pharmacies that are billing for these products. So I just want to get your input on that.
Yeah, absolutely. So, I understand your concern, and you're not the first pharmacist to reach out to us about this. So I'll just backtrack and kind of provide some background on NADAC pricing. So, to begin with, manufacturers typically increase their prices in January and July. And subsequently, CMS has to make those updates via their vendor, Myers and Stauffer. So Myers and Stauffer updates the pricing files, and then it's subsequently sent to the respective PBMs. So, all of that really takes time in these months, January and July. So with that being said, some of the NADAC pricing that was updated in the beginning of January was not updated in the PBM system until late January to early February, and that's just the nature of the business here, and the files that come from CMS. So, rest assured that, the pricing files are, coming in on a regular basis to MedImpact and to Magellan. And, there are certainly opportunities to appeal NADAC pricing via CMS's vendor, Myers and Stauffer. And I can put that information here in the chat for everyone's information. So that's, kind of the background of NADAC pricing and why there's a little bit of a delay. So that's why you're seeing that lag time between the price increases and the reimbursement.
I don't know who has, I guess, influence on NADAC, but it seems like this day and time, Myers Stauffer is a national accounting firm. It certainly seems like to me that as old as First Data Bank is and other places, that, they can load their prices pretty quick. So it seems kind of antiquated that they're using an accounting firm to update these, I guess, manually. And maybe I'm wrong on that. Maybe they have a better way of doing it. But certainly when we are, when a price goes up for a pharmacy, which like it was recent here in June, I know on my Janumed, Jardiance, Januvia, all of them went up $20 and $30 a bottle. I didn't get a say so in that, well, wait a minute, I'm going to pay that lower price because my NADAC's not updated. So there's got to be a better way that they're looking at this. And again, I know that's a federal program or federal pricing program. So do you know of any influence or any contact information that we could work with our congressman on trying to get this program to be a little bit more efficient?
Yeah, so I've
Hey, Rob, Jill with NACDS. I thought that NADAC got updated monthly. So is it an issue? Is it actually a NADAC issue, or is it the PBM or the state is not capturing those price updates or using the latest NADAC list? Can you, Claire? I guess that was kind of a question and a statement and a clarification.
Sure. So, the significant price increases come in on in January and in July. So while NADAC price files are sent more frequently than, every 6 months, the updates don't reflect as quickly when we see those big price hikes from CMS and their vendors. And subsequently, depending on when those price increases go into CMS's system, then, the PBMs get those files and then they upload it into their system. So yeah, there is a little bit of that lag time, notably in January and July. So, it's just a matter of waiting for that lag time to, trickle down and get into the PBM system, and subsequently, pharmacies would be instructed to reverse and rebill and get that proper reimbursement.
Okay, that's certainly not been the case with me. I don't get too many notifications. I mean, I know we did with Med Impact on the one issue, and that was fixed, but I mean, even when I have an appeal, I mean, there's very few times where it says reverse and rebill. So I didn't know. I don't know if Rosemary, you have notifications like that.
So Ron, we're also happy to, work with you and look at some claim examples and see, what the root cause of the issue is. If you want to send those examples over to us, we're happy to do that.
Okay.
And Ron, I just copied the information Fatima sent in the chat and I emailed it to the pharmacy TAC, and Kathy,
Okay.
I copied you on it as well.
Okay. I just saw that. Thank you.
You're welcome.
In a perfect world, if we could get the manufacturers to, say, you can't raise the prices until NADAC's updated or whatever pricing is updated, that would be wonderful. But the main thing, I guess, Fatima, is we want to make sure that there's not a lag in, Med Impact or Magellan in loading that. So, I mean, I would assume that, when it's updated in NADAC, it's updated there. Would that be a good assumption?
When a drug manufacturer increases their price, it's updated immediately with NADAC and then subsequently within the PBM system. Is that what you're saying?
So well, my question is that for Med Impact and Magellan, the two payers right now, when NADAC updates their pricing, is it automatically updated in Magellan and Med Impact, or do they have a process to update that?
Yes, they do have a process, and they're probably better to explain it than myself. So I'll hand it over to a representative from Med Impact.
Okay.
Thanks, Fatima. So yes, just to kind of do some background, everything Fatima was saying is correct. Myers and Stauffer, CMS's vendor, updates the NADAC files both on a weekly and a monthly frequency. They're updated weekly based off of changes like for provider inquiries, help desk calls, and increases in brand manufacturing prices. So what I think I heard you say earlier is that the manufacturer increases the WAC or AWP. That is then what triggers the NADAC to get updated. So that goes up, Myers gets that, it updates the NADAC. And then that gets posted on the following week, like to CMS's website on a Wednesday file. It is an Excel file that is on CMS's website. So Med Impact, Magellan Systems, they don't go down and grab it. We use First Data Bank Metaspan, drug compendia vendors to feed us that data. So what happens, this delay, that Fatima was talking about, is that the NADAC file gets updated. Those drug compendia companies go and pull down that new NADAC information. They update their files, and then it gets loaded into our system. We're on a daily update from our drug compendia vendors, so we get it as soon as we can, but there is that inherent delay. Does that make sense?
Well, to try to, I guess, make your timeline more concrete from, let's just say Januvia goes up it doesn't make a difference what day of the week, but just say Monday.
Mhm.
Typically, when's it gonna be updated in Magellan?
So
Or
it's all,
at
so it's
Impact?
all dependent upon when the manufacturer alerts First Data Bank and Metaspan. So let's say, like you said, Januvia goes up 10%, the WAC goes up 10%, and that goes in your, up in your system, your point of sale system immediately. So let's say they update First Data Bank that same day. Well, then it will take Myers and Stauffer a week, to get it in their First Data Bank system, potentially. Then they use it, they update the NADAC 10% to reflect, the 10% increase in Januvia. Then they send it to CMS. CMS has to review, agree on it. They post it to the CMS website that Wednesday. So you're potentially a week and a half out. Then First Data Bank and Metaspan have to pull it into their systems and then send it out to Magellan, MedImpact, any PBM. So it could be 2 to 3 weeks. But for brand products that go up, the effective date of that 10% increase in NADAC is going to be backdated to match the effective date of that WAC change. So if it was July 1st, even if it gets published, that you don't see the increase, that 10% increase in NADAC in our system until July 15th, it would be effective 7/1.
So could I ask a quick question? So does the pharmacy have to go back and reverse and rebill to
Yes,
see that?
they would have to.
Okay.
Because
right
all we can
now-
do is
yeah.
adjudicate claims with the rates that are in our system as of that point in time. And when the pharmacy adjudicated the claim, our system still showed the old NADAC rate. Now that we've had a subsequent update, on the daily file, that's potentially 3 weeks out. Now our system has been updated, but when that claim adjudicated, that data did not exist in our system. And NADAC's change, like Fatima mentioned, on a weekly basis, there's no way we could reverse and reprocess claims on a weekly basis of this volume based. It's just the methodology of the NADAC. And just Magellan, MedImpact, DMS, we do not control the methodology of the NADAC. That is all from CMS.
Okay, then we're just supposed to figure out that there was a price increase and,
So I think there's a couple
it
different
was,
ways.
or are we going to be informed by MedImpact and Magellan?
So CMS, so again, the owner of the NADAC, CMS, they do have a file on their website. So they have like the whole NADAC file, which you, again, wouldn't want to come down through, but they have what's called a week-to-week comparison, and it identifies what drugs, change from last week to this week. So those are going to be the drugs that, potentially would have had a rate change in our system. So you can look at that each week and see which ones, potentially could need to be reversed and reprocessed. That's an idea that comes to mind.
As you can see from a business owner standpoint, this is tough news. I mean, when you're already covered up and trying to keep up every day, and then you have to go back and, I don't know how many claims. It's going to depend on
The week.
the company and the particular week or whatever. It could be a lot of just, we don't have an automation system in our softwares that can just say, okay, here's these 100 claims, just go back and rebill them, reverse and rebill. So maybe that's something we need to ask for, but as you can tell, if you put yourself in our shoes, that's not real welcome news. I mean, if somebody sent us a report that showed us exactly, here was the price update, this was paid at this price, you need to reverse and rebill, that would be great. But I would dare say that 90-some% of the pharmacies out there don't know about the site you're talking about, or the part of the site that you're talking about that would inform us of that. So could you please send that to me or Aaron or both? And we need to get that information disseminated out to every Medicaid provider pharmacy.
So I want to make sure I understand the ask. What would be disseminated to every Medicaid provider?
No, I mean,
Just-
I would like for everybody to know where to go to
Oh, okay, yeah,
get that information.
that information, sure. Yeah,
Instead
absolutely.
of them
Let me pull
having
it up.
all have to hunt for it all the time.
Yeah, let me see if I can, while we're, talking, pull up the website, and then can share it in the chat here.
Can you also please identify your name for the court reporter, please?
Oh, sure. So my name is Adrienne McCormick. I am with Med Impact. I am the account exec for the Kentucky single PBM account. But prior to that, I worked 13 years in consulting with Myers and Stauffer and Mercer and worked on the development and design, and helped multiple states implement the NADIC. So do have a lot of experience working with this. And, some of the comments that you're saying, definitely have heard other states, state Medicaid providers, voice similar, concerns, and just kind of just something to have to work around with the way the NADIC is designed, because the increase in the WAC or the AWP is what triggers the NADIC update and not the other way around.
Do you see, since you were a consultant with Myers and Stauffer, do you see any way that week-long process could be on average? I'm assuming you're just doing it on average, that could be reduced or made more efficient in some way?
Honestly, I don't work there anymore, so I definitely don't want to speak for them, but I do know that a lot of discussion with First Data Bank, Metaspan, all hands were at the table to try to figure out how could we get the data, into the point of sale systems as soon as possible. So I know a lot of that work was done on the front end. And this is kind of where the process that I described is where it was ultimately landed. And a lot of it depends on, who the vendor is. Some vendors are on like a daily update, some are on a weekly, and some are on a monthly. So there's so many levers that go into it to fully answer that question. But I know, I can't speak for Magellan, but I know Med Impact is on a daily update feed, meaning that we're getting the data as soon as possible to capture those NADAC price increases from First Data Bank and Metaspan.
Okay. Well, not to put you on the spot, but do you want to, we'll move on, but if you want to please forward that to Aaron and myself, and then I guess we'll figure out a way to get this information out to everyone in the state that can look at that report. Does that report come out weekly or every day, or?
I said the NADIC rates are only updated every week, so it would come out weekly. And maybe one other thing to clarify in there, we talked about how with the, I think you used Januvia as the example. So the WAC increased 10% and then the NADIC increased 10%, and then the effective date of the NADIC is backdated to the effective date of the WAC change. That is only true for brand pricing changes. So the generics, which are updated on a monthly, that's going to occur, like, I think it's typically effective like the first of the month or something. I can't remember exactly, but it's for the brand increases that happens.
Okay. So
Just
we wouldn't ever have a situation where we would be able to reverse and rebill on generic drug price increases?
To my understanding, no. I think the thought behind that is you have so many different generic manufacturers. So, how do you attribute that to, the average price for atorvastatin 10 milligram? If you have 10 different manufacturers and 2 of the manufacturers update the price, but the other 8 don't, how do you even do that? I think so. That was the thought behind that. So I think it's only for brand products that are updated based off of a WAC change.
Okay,
Because there would be times where brand products are just updated because new price points come in and it has nothing to do with the WAC or AWP change. Um, so there's going to be monthly updates that, wouldn't be retroactive. It's typically just those weekly updates. And, like Fatima said, you're going to see a ton in January when manufacturers update their price. You're going to see a ton in July. And I think there's some manufacturers do like, a May or a fall date, but typically the bulk of them are in those 2 months. So I'm looking to see if I can find it. If I don't find it while we're still on this call, I will make sure I send it to, Fatima or respond all to this group. I think Ron, your contact information's on here and then they can get it out.
okay, I appreciate that.
Sure.
Okay. So sticking. I don't think we have any action items to go along with this. I mean, we've heard from an expert here that, with her background at Meyer Stauffer's, that, they're hopefully we're going to be able to get the information out to everyone. I guess we could make a motion to make sure that we let every pharmacy provider in the state aware of this site, to where they can look at it on a weekly basis to see what claims they need to reverse and rebill. I think that would be very useful to everybody. I would like to know the percentage of people right now that do that. I know I've been unaware of that, but I'm not saying I'm the best either. We got a lot of things to think about. So if you all feel the necessity to make that motion, because I feel that a lot of pharmacy providers, whether chain, whether independent, whether hospital, would appreciate knowing that.
Ron, I agree, because in my role, they'll call and ask these questions, and we do try to refer them to filing an appeal on the site that you mentioned for the NADAC. But, most of them, they're operating on very thin budgets and have to make tough decisions. And so they're trying their best, and it's just one more thing. So anything that we can do to help them recognize those claims that they, can potentially go back and reprocess and rebill would be very helpful. But I didn't know about this site either. So thank you for that.
Okay.
And I agree with you too. I didn't know about this site. I don't think any of our KIPA members knew about it either. So I would like to make that motion as you proposed.
Okay. Motion by Rosemary,
I'll second. This is Paula.
second by Paula. Any further discussion? All those in favor say aye.
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 Any opposed? Okay. All right. Ordinarily, we would always have on general discussion in the future, we might have some people that want to bring some things up. That's fine. Our MAC meeting on the 28th, or that's coming up for next Thursday, a week from tomorrow. I should be able to do that, Kathy, and I appreciate several of you, unfortunately, Meredith being one of them. She'll respond to me, but it's always that, some pharmacist didn't show up for, that had COVID and I have to fill in, or, some crazy stuff that we've all been dealing with. But I do appreciate the responses I get when I ask somebody to present and they're like, Ron, I can't this time, but hit me up next time or something. But I shouldn't have any problem on the 28th. I know that the chair, Elizabeth, is it Purton, Kathy? I'm trying to remember that.
Pardon.
Pardon, sorry. Dr. Parton, I know that she tries to do her best to get get through those pretty quick. She's really efficient at that, so we don't have to be on there forever. So, and she'll change the order up. So if you're next to last, you don't have to be next to last every time. So anyway, if there's nothing else,
And I have
Yes.
one thing to just clarify.
yes,
Um, You had mentioned that the next PNT meeting is in November. It's actually in September 15th. But the eczema products will be reviewed with the dermatologics, which are reviewed in November. So just wanted
okay,
to do that for
okay.
everybody.
Okay, sounds great. The biggest thing is just their meeting, because I know for, before your time, Fatima, there's a lot of times that they couldn't get a quorum together to get
Right.
that committee going. So now it seems like they are meeting and they're doing the good work. So I'm glad to hear that.
Yep.
And thanks for your all's responses from our last meeting, and certainly I'll send these to Aaron and we'll get it brought up at the MAC. Okay.
Sounds good.
Okay. Do I have a motion to adjourn?
Motion.
Motion by Philip,
Second.
second by Meredith. All in favor, say aye.
Aye.
Thank you all very much. Try to stay cool.
Thanks, guys.
Thank you. Have a great
Thank you all.
afternoon.